thiamine deficiency. What's the problem here? Thiamine is not there. Thiamine is deficient. As we all know that in alcoholics, they usually forget to take their nu- nutrition seriously, and it's not very like common in all. As we have seen many alcoholics which have never ever developed this thing because their diet is fine. Their diet is have rich amount of thiamine, and so that's why they are not having that Wernicke-Korsakoff syndrome. So this syndrome occurs in if the patient is having poor nutrition or patient is having any malabsorption. So this thing is important. What is it? Necrotic lesions, mammillary bodies, thalamus, and brainstem. These are the CT or MRI findings and Wernicke-Korsakoff and Wernicke's encephalopathy, acute and reversible. This thing is important that this is reversible, but we have read that in elderly these things some sort of cognitive decline is there, and that's not totally reversible. So it's mostly reversible in adolescent and young people and middle-aged. So Wernicke's encephalopathy, acute and reversible, triad of oculomotor dysfunction such as nystagmus, cranial nerve 6 palsy, eye pointing inward, gait ataxia, and confusion, if untreated, may progress to Korsakoff syndrome. So if we are fail to treat the Wernicke's, then Korsakoff will develop. Korsakoff syndrome is chronic and only 20% reversible with treatment. This thing is very important. That Wernicke's is like reversible, but once patient has developed Korsakoff syndrome, only 20% cases are reversible. Anterograde amnesia. What is Korsakoff? It's anterograde amnesia and compensatory confabulation cannot occur only during an acute delirium or dementia and must persist beyond usual duration of intoxication and withdrawal. So this Korsakoff is present like even when the patient is not using alcohol, that he is confabulating, that he is what is confabulation? That's the fabrication of imaginary experiences to compensate the memory loss, because they are having the antegrade amnesia. That's why they are like fabricating it, their memory deficit, they are fabricating it. So what's the management? Management is Wernicke's preventive treatment. Any patient with withdrawal, as we have already read, that the protocol is we are going to give thiamine. And in Wernicke's patient, what is the thiamine dose? 100 to 250 milligram IM IV, one dose, single dose is there. And Wernicke's acute treatment, thiamine 500 milligram IV, BID or TID into for 72 hours. Then reassess the patient, and if we that's the clinical judgment. So Korsakoff treatment is IV treatment as for Wernicke's, followed by thiamine 100 milligram per oral, TID 3 to 12 months. So there's a long-term there's a 3 to 12 months we have to treat for Korsakoff. And what is the treatment of alcohol use disorder? So we have read it in the previously in the family medicine that we use what behavioral non-pharmacological intervention and then pharmacological intervention. The three famous drugs which are used for alcohol dependence or use disorder are naltrexone, acamprostate, or disulfiram. And now I'm going to read individually that what are the indications, what is the mechanism of action of each drug. So naltrexone, which is brand name is Revia, which is opioid antagonist, shows to be successful in reducing the high associated with alcohol, moderately effective in reducing cravings, frequency or intensity of alcohol binges, can be started if still consuming alcohol or abstinent, but can precipitate withdrawal in those with physical opioid dependence, which I have mentioned before. That in opioid dependent patient we should be careful while using naltrexone. So acamprostate Campral, which is NDMA glutamate receptor antagonist, useful in maintaining abstinence and decreasing craving. So this decreases craving, and naltrexone reduces the highs. And disulfiram, which is anti-abuse, this is not used in Canada now, but we can read it because they have mentioned it, so we should read it. Prevent oxidation of alcohol. block acetaldehyde dehydrogenase and causes an adverse reaction to alcohol, nausea, vomiting, tachycardia, shortness of breath, headache. If patient relapses, must wait 48 hours before starting antabuse, prescribed only when treatment goal is abstinence. Randomized controlled trial evidence is generally poor or negative due to poor medication adherence. Contraindications are severe renal disease, pregnancy, psychosis, and cardiac disease. Some evidence for the use of gabapentin, topiramate, ondansetron as anti-craving agents, but not approved by Health Canada, approved for this indication, currently under investigation. So, alcohol use disorder is complete here.